When understanding what makes an electronic health record useful for clinicians, I think it's important that the focus is on features which are immediately useful to the user logged in and not features which are of benefits to others down the road. And a heuristic or a way to think about the usefulness of an EHR is along two different categories. The first category is the time frame. Is this feature useful to me now, or is this feature of use later? The second is, who's this feature or this function useful for? Is it useful for me, or is it useful for others? You can plot on a 2x2 grid these two categories. So on the horizontal, you could have time, and then on the vertical y-axis, you could have benefits to others. This would mean that the bottom left quadrant is things which are immediately useful to me. And the opposite extreme is the top right quadrant, which are items of delayed usefulness to other people. And now, if the goal is to build an EHR that clinicians will eagerly adopt, especially over their existing paper-based workflows, we must start in the bottom left quadrant. The first priority must be to build features that are immediately useful to the clinician logged in. Too often in EHR design and implementation, we try to convince clinicians to use an EHR based on features from the top right quadrant, features that are useful down the road to other people. Now, these other people might be other clinicians or other administrators or patients, and humans are altruistic and do want to do additional work to help other people. But focusing on these delayed benefits, especially when the benefit is for other people, is a tough sell when we are trying to build more of a viral product and trying to meet the needs of very, very busy clinicians. And so in short, start by focusing on features which are of immediate utility to the person logged in. One caveat is to be very aware of network effects. If you're installing an EHR for the first time in an organization, what features are available to be of immediate benefit cannot rely on past usage of that EHR or of any network effects, meaning no immediate benefit could be proposed to a clinician that they're able to see the patient's history, because the first time they log in, the patient won't have had their history entered into the system. And so it's very important that the immediate benefits must be possible to achieve even without a clinician ever having logged into that system before. Just an example, in one hospital I worked in, one of the benefits was that you could, in theory, display the patient's past medical history list. But in order to display this list, the user had to manually enter, via a reasonably cumbersome process, all the issues. Now, of course, there are collective benefits if everyone entered this information and kept it up to date. However, even after a decade of using this system in the hospital, really nobody did this. Clinicians are so busy during their day that they would avoid taking on any extra work, even if they know that the extra work might help other people down the road. Let's look at some examples, perhaps, of features that might be in each quadrant. And now this example list isn't to be all-inclusive of all the features and benefits of an EHR, but to show how you could use this heuristic to evaluate priorities. And the order of the quadrants we're going to go through will be from those which provide the most immediate value to the user to the most distant value to the user. So bottom left, it's valuable or useful immediately to me. The two big areas in this would be things that make my data review workflows faster and things that make my data capture workflows faster. For instance, the data review workflow could be things which show me information I have to hunt for on paper, such as lab data or imaging data. And ideally, this data can be auto-dumped into the EHR from other systems and databases without the clinician. So it's already available to the clinician the first time they log in. Alternatively, you could show the clinician important contact information of people that they need to access or places, or you could provide quick access to the protocols or the policies for the group that they work for in the hospital or the clinic. Trying to make the data capture workflow faster means being able to capture that patient assessment, the plan, in that digital tool in a way which is faster and more comprehensive than on paper. So this might be using intelligent workflows to help write the notes quicker, making it faster to book an appointment for a patient than having to book an appointment on paper, or making it faster to order a home follow-up visit than having to do this on paper. Other ways to provide immediate benefit would be to add something such as access to clinical support, such as, let's say, a digital consultation in real time, or enabling a clinician to bill more for their patients and reduce their billing paperwork. Benefits that might benefit the person logged in, but at a delayed stage, might include things such as the ability to retrieve information that I had previously entered about a patient. And this is how most clinicians currently view the utility of an EHR in the US in primary care. Most physicians just see that the EHR is really an elaborate filing cabinet, which I think is, as we've discussed in previous blog posts, a very narrow way to think about the value of an EHR, and it's probably because the EHR is not delivering on other areas of value that they could be. Other benefits which are delayed value to the clinician include, for instance, coming into clinic and not having that clinic being overbooked, because when the initial patient booking was made, they were able to do this digitally, and so they could see at the time how busy each day was when the patient was initially booked into clinic. Or perhaps a delayed benefit will be the actual reminder that a clinician experiences to follow up on a test or a lab result. The next category of benefits are those which are of benefits to others. And so we now move up into the top left quadrant, which is immediately of benefit to others. And this might be in that others may have quicker access to the notes that I write, or that other people working in the same clinic as I am might be able to see what patient I'm assessing during that period of time. There also might be improved quality of care that the patient receives. So this might be through things such as clinical decision support, and this would be an immediate benefit to the patient. Or it might reduce the medication order errors that I produce, which would be a benefit to both the patient and the pharmacy. Or it might make it easier for staff to identify which patients missed clinic that day if I chart my encounters through a digital tool. And now we end up in the top right quadrant. This is of delayed utility for other people. And the big one, of course, is that EHRs make producing aggregate quality reports or aggregate reports on a weekly or a daily or a monthly basis much easier for the organization. And they reduce the number of paper charts that need to be filed and retrieved. I think this is of huge value, but I think that this is of not immediate value to the person putting in the information the first time. And so therefore, I think it's important to realize that when I suggest that a feature is in the top right quadrant, I'm not saying that features that are delayed for others are low value features. I'm just suggesting that these are more of distant value features to the clinician. And so therefore, when building the EHR tool that we want the clinician to really want to use, we need to have enough compelling immediate benefit features that help answer the why should I care about this right now question when I'm working in a very busy clinic. And one of the considerations would be that if the process of implementing an EHR ends up creating benefits for other people in the organization, but those benefits come at the cost of additional work for the actual clinician who is logged in, it's even more critical that additional immediate value is provided to that clinician who's logged in to offset the potential other work that they have to do. For instance, the example above, let's say that one of the benefits of the EHR is that you can produce another type of report, which is of very high value to an organization, and when their workflows was on paper, this report wouldn't be produced. Well, if the clinician now is collecting additional information to produce that report, it's going to increase their total burden of work they have to do to provide care. So therefore, we need to optimize other parts of the EHR system to reduce their clinical burden in those areas in order to make room for the increased work which the EHR is bringing in, so that the net benefit is still in favor of immediate value to that clinical user. I think the next area of discussion should perhaps talk around one of these common themes which we've been discussing, which is how speed or efficiency affects the value or utility of a clinical system, and a way to think about that.